Hi, everyone. Welcome to our lecture for Module 1 of PrePracticum class, EDE 449 at the Warner School of Education at the University of Rochester. I'm Dr. Lustica, and I will be doing these lectures for you for this class. So for Module 1, we're talking about the biopsychosocial model of mental health. This lecture will be about 20 minutes long. I suggest that you do take some notes because the assignments that you have will be based upon the stuff that you learn during this talk. So when we talk about the biopsychosocial model of mental health, we have to go backwards a little bit, and we have to talk about the biomedical model because that's what came first. So the biomedical model was the model that dominated everything since the mid-20th century. And this model is exactly what it sounds like, right? The emphasis was on a biochemical alteration in the body. So this said that all illnesses had something to do with some sort of biochemical alteration in the body. And that was physical illness and psychological illness. So the emphasis was on disease, right? Signs, symptoms, and lab testing. So think about when you have strep throat, you go to the doctor, they swab your throat, they send it to the lab. Okay, it comes back, you have strep throat, right? Or you have something going on, you need blood work, you go to the lab, you get your blood work done, you come back. As we know, for mental health, we don't have a blood test or a swab or, some sort of lab test that we can send away to say, yes, this client has anxiety or this client has depression. So the biomedical model was really, really focused on illness as a result of some kind of biochemical something happening in the body. But there were criticisms around this model. And so the criticisms were that the model didn't account for subjective experiences. So it doesn't account for what the client or the patient in this case was experiencing, right? It was all about these tests that could be done. It limited treatment to medication. So I have strep throat, I go to the doctors, I get my prescription, I'm good to go, right? There was no talk of any alternative kind of treatments. And then it didn't take into account the relationship between the clinician and the client. And as you know, and as you'll continue to learn, the relationship between you and your clients is one of the biggest factors of change. So the biomedical model didn't have a relationship between the physician and the patient or the clinician or the client at that time. It was all about, let me take this test, let me see what's wrong, let me get some meds, let me move forward. So that was the model that was happening up until the mid-20th century. So I want to introduce you to George Engel, Dr. George Engel, and I'm going to tell you his story. And his story is very cool, especially for us that are at the University of Rochester. So George Engel was born in New York City. He was a prominent clinician and medical scientist. He's best known for his work on subacute bacterial, and that was his work as a physician. He was an undergraduate at Dartmouth College, and then he went to Johns Hopkins University of Medicine. And then the following year, he was funded by the Rockefeller Foundation to spend 2 months at the Leningrad Institute of Experimental Medicine. So he received his medical degree from Hopkins in 1938. So think about the time frame, right? The medical model was prevalent in this time. So in 1938, he began an internship at Mount Sinai Hospital, where he worked with other physicians who were really interested in incorporating psychosomatics into clinical service. But at this point in 1938, Dr. Engel, was very skeptical of psychoanalysis and psychosomatic medicine, and he remained committed to that biomedical model of illness. So in 1941, he was appointed a research fellow in medicine at Harvard Medical School. And here he collaborated with two other professors, two other doctors, on a study of delusional patients. So they did this study, and the study absolutely changed Dr. Engel's mind about the purely physical explanations of disease process. So this is where it gets very cool. So that was 1941. In 1946, he was offered the opportunity to establish an entirely new psychiatric department right here at the University of Rochester School of Medicine and Dentistry. So he had a dual appointment in psychiatry and medicine. and he established a medical psychiatric liaison service staffed largely by internists, became deeply involved in the incorporation of psychiatric training at the medical school and in the medical school curriculum, and began his own training as a psychoanalyst. Right here, the exact place where you are. He did this all at the University of Rochester. So by the mid-1950s, he was one of the leading figures in psychosomatic studies. He was prominent in the American Psychosomatic Society. He edited its journal. He began publishing numerous books and articles on the relation of emotion and disease and on the incorporation of these ideas into medical training and clinical practice. So that study that he did changed the way that he did everything. And then we were very lucky, he came to the University of Rochester and then really started the collaboration between psychiatry and medicine. So under his direction, the program in Rochester became a leading center in the development of psychosomatic theory and training. And he is the father of the biopsychosocial model. So the model that is used all over the world was created right where you're sitting, right at the University of Rochester. So I think that that's very cool. So what is the biopsychosocial model of health? So Dr. Enger offered a holistic alternative to the biomedical model. He said that illness is the result of the interplay of biological, psychological, and social factors, plus individual health-related behaviors. So he said what affects the body will also affect the mind, and what affects the mind will also affect the body. Therefore, wellness and illness go beyond a person's physical state and is impacted by psychological and social factors as well. So you can see on the right of your screen, there's that little Venn diagram. You know, you have your psychological factors, you have your biological factors, you have your social factors, and we're going to go into what each one of those are. So biological is your physiological pathology. Psychological are your thoughts, your emotions and behaviors, psychological distress, fear, avoidance, beliefs, coping methods, all those things you guys are already experts on. And then your social factors are your environmental factors. So socioeconomical, cultural factors, what's happening at work, what's happening in your family, what's happening in your interpersonal relationships. And all of those things come together to make you a human and impact both your physical and your psychological health. So let's start with biology. So the biological factors inside the model are genetic vulnerability. So we know that genes play a big role in what we experience as individuals, right? So any kind of genetic vulnerability you have to disease is under this in that biological circle. Your physical health both now, where you are in your current state, and the history of your physical health as well. Any sort of disability that you might have, a history of physical and psychological trauma, right? Trauma changes the brain, so that can fall under that biological circle. Neurochemistry, which is the study of the chemical makeup and activities of your nervous system. It's the chemical processes and phenomena related to the nervous system. So your neurochemistry is in that biological circle. Your diet, your lifestyle, do you exercise, right? Your immune response, are you immunocompromised? Any effects of drugs, any drugs that you're taking now that have physical side effects, or any drugs that you have taken up until now that have had physical side effects. Your stress response. So your stress response directly impacts the level of cortisol in your body. And we know that your stress response can have all sorts of physical symptoms for you, right? So that goes in that biological circle as well. And then emotions. Any sort of emotions can be in the biological circle. You're going to notice that emotions are in a couple of those circles, but there definitely can be a biological predisposition to emotions. Then you've got the psychological factors. These are all the things that you guys are already experts in and that you're going to learn more about throughout this program. So your personality, your attitudes and beliefs about the world, your self-esteem, not only your self-esteem now, but your self-esteem from the time you were little and can remember having a self-esteem up until now. Your perceptions about the world. Again, there's those emotions, right? You can have psychological emotions that are in that circle. Any sort of trauma that you've been exposed to, any sort of grief or loss that you've had, and then your coping skills. How do you cope with all of the things that are happening in your life? And then your social skills. What do your interpersonal relationships look like? What do your attending skills look like? Are you able to have empathy? Are you able to actively listen? All of those kind of things that go in that psychological circle. And then lastly, you've got your social circle, and this includes the environment with which you're in. So all of those things around you. So work, school, interpersonal relationships, right? Your relationships with your friends, your relationships with your family, your relationships with your significant other, your socioeconomic status. This plays a big part in your environment because your socioeconomic status has a direct correlation to the access that you have to things that you need. And things like healthcare, right? Or education, all of those access things that you need. The peer group that you hang out with, not only the peer group now, but the peer group you hung out with your whole life, right? How has that impacted you as a human being? Your lifestyle, any sort of societal norms. Think about the norms in society for those that identify as female, or those that identify as male, or those that are of different cultures or different races. There's all these kind of societal norms for being a mom or being a dad or being a parent. All of those things impact you. Your level of education also impacts you. That goes back to socioeconomic status too. So what access level to education did you even have? And then where is your education taking you? Your family circumstances, both your family of origin and the family that you create for yourself now, right? Those are all part of your environment. And then any kind of history or current abuse or neglect that is happening to you. So what happens is that the biopsychosocial model takes all of those factors and they put them in those circles in that Venn diagram. In the middle of those circles is your mental health. So think back to the biomedical model. It feels, as a counselor, to me, primitive to think that everything in our body is coming from some sort of biological factor, right? It makes much more sense that all of these factors are coming into play for a person's both physical and mental health. So this is very cool. This is a really great way to do assessment, and it's a really great framework for assessment. It's one that I've used for a very long time, and it really gives a really holistic overview of the client or the person that you're working with. So the biopsychosocial model, it's called the 4 Ps. So the first thing that we have to talk about when we talk about the 4 Ps is the difference between diagnosis and formulation. So in your problem ID class that everybody is also taking, we talk a lot about formulating a course case conceptualization. So it's kind of the same thing here. So diagnosis is not the same thing as a formulation. In mental health, when there's a group of consistent symptoms seen in a population, these symptoms can be categorized into a distinct entity called a diagnosis. So the formulation is, what are all of the things that are happening in this client's life? What are the symptoms that they're experiencing, and how do these symptoms correlate with the diagnostic criteria in the DSM-5-TR to come up with a diagnosis? And this 4 Ps of the biopsychosocial model is really going to help you to do that. So we're going to go through each one. The 4 Ps are predisposing factors, precipitating factors, perpetuating factors, and protective factors, right? So the predisposing factors of your client is, what is their setup? What were they initially working with? What did they come to you with in their, suitcase of experience of life? All those predisposing factors. What are they already there with? The precipitating factors is, what acute event happened and how did it initially affect them? Why are they in counseling? What happened to them? What was the effect of that event? Perpetuating factors are what chronic things are going on. What has happened in their life from the moment they were in utero to now? All those chronic things that are happening. And then protective factors. This is what I really like about this model, because we're going to talk a lot about risk and protective factors throughout this program, especially when you get into your internship. And I think folks sometimes get confused with risk and protective factors, and they say things like, well, protective factors are client variables like the client is very nice, the client has a good sense of humor, and those are all really great things, but those are not the protective factors that we're talking about. We're talking about the global factors that are protecting your clients and that are keeping them well. So linked into this PowerPoint and in your assignments are these 4 Ps of the biopsychosocial model. So I'm going to go to that now, and I want to go a little bit more in depth because this is how you actually do the assessment. So we're going to go through each one of these. So this chart, you can look at the bottom. This was adapted from Barker P., the Child and Adolescent Psychiatry Evaluation from 1995. So it is a little dated, but it's, I think, really great and really helpful. So this is the 4-part chart for the 4 Ps of the biopsychosocial model. And on the left are all of those questions. And then the next 3 columns break it up into the biological, psychological, and social circles of the model. So when your client comes in, when we're thinking about the predisposing question, so what is their setup? What were they working with initially? In the biological range, we're thinking of all of these questions in here. So this is something that you can gather at intake with your client. This is also something that you can go back and keep filling in session after session as you develop rapport and a relationship with that client. So thinking about the biological factors of predisposing, what was their temperament at birth? What were they like as a child? What were they like as a baby? What were they like as a teenager, right? And how did that temperament play with the other folks in their family? So their temperament is very important. What do we know about their consistent personality characteristics? What have always been there? What do they remember always being like and is still like today? Is there a family psychiatric history, right? Maternal side, what's that look like? Paternal side, what's that look like? Was your client adopted? Do they understand or do they even know about their birth family? All of these things are very important information for you and for your client as you continue to work together. Are there toxic exposures in utero? So we know now through lots of research that what happens to the mother while a baby is in utero also happens to the baby, right? What the mother's exposed to, the baby is also exposed to, and that can be a toxic in the environment, that can be toxic stress, that can be abuse, domestic violence. So understanding that information is important. What is their birth story? Were there birth complications? Did they have any developmental disorders? What is their neurodevelopment history? Did they hit all their milestones when they were supposed to hit their milestones? And do they have a history of concussions or traumatic brain injuries? Has something happened biologically before they even have shown up to you in the session that might be impacting what's happening with them now? And then for predisposing, you look at the psychological factors. What is their attachment style? We're going to talk a lot about attachment, and any of you that work with kids, you know what attachment theory is and what attachment styles are, I hope. So what was their attachment style to their primary caregiver? How did their family act, and what is their family structure, right? What did their family look like growing up? What does their family look like now? And is there any dissonance between the two? Do they have problems with affect modulation? How are they with their moods? Can they regulate their emotions? How were they when they were a kid? How up until the time that they were born till now? Has that changed? Has it looked different? Does it look the same? Do they have rigid or negative cognition styles? So this is like rigidity in thinking. That's a phrase that I probably use often, like they're very rigid in their thinking. Or negative cognition, they have, they're kind of pessimistic in their views, or they feel sad a lot, or their affect is not there, right? They're missing affect when they should have affect. And then what's their self-esteem and self-image? So all of those fall into the psychological realm. What was their self-esteem and self-image before they even showed up in your office today? And then under the social realm, did they grow up in poverty? Are they living in poverty now? What is their socioeconomic status, and how that relates to the access of medical and psychological treatment that they can get? If they're parents, when did they become parents? Did they have access to healthcare? what kind of exposure did they have both in utero and as a child? So any sort of maternal depression, domestic violence, were they adopted? If they were adopted, when were they adopted? Were they in the foster care system? What was their temperament? Temperament mismatches speaks to the temperament of the child and the temperament of the caregiver. So was the caregiver able to meet their needs as a child based on the temperaments of both of them? Were they, subjected to marital conflicts, or in their life right now, is there marital conflicts? Do they have a history of immigration, racism, marginalization, discrimination? All of that stuff plays in, and it changes your composition as a human being. Exposure to antisocial personality traits. So were they around folks who demonstrated those antisocial personality traits, and how did that affect them? Those are all those predisposing questions. So all of those things, again, that happened even before they sat down in your office. And then you move on to the precipitating events. So what acute event happened and how did it affect them? So why are they there? Biologically, did they have some sort of serious medical illness or injury? Are they using alcohol or drugs, and what is that doing to their body from a biological standpoint? Are they on medication? Do they take their medication? Are they pregnant? Are there hormonal changes? Are they going through menopause? All of those things have a big toll on the body. And then sleep. Sleep is huge, huge, huge. It's one of the things that can so easily be changed in terms of lifestyle, and folks don't think about it. So are they sleep deprived? Do they have a regular sleep schedule? All of that stuff is going to, regulate your biological body or not. And then psychologically, for the precipitating factors, the acute event that happened, what happened? What stressor happened that activated one or more psychological processes? And you'll see under the psychological chart, it's broken into these psychological processes. So cognition, dialectical, interpersonal, and psychodynamic. So under cognition, what stressor happened that kind of rocked their core beliefs? What is happening for them to have kind of cognitive distortions, right? Thinking about things that aren't true. What happened to them under the dialectical that emotionally dysregulated them, right? What led to emotional dysfunction? What acute event? And then interpersonal, what happened? Was it grief? Was it loss? Did someone get in a disagreement? Was it a change? Was it a transition? Was it it could even be a good transition. Sometimes that can bring up stuff that you didn't recognize was there. And then psychodynamic, this is fun. This is when you get to tap into your knowledge of Freud and your knowledge as a counselor and think about unconscious conflicts and defenses, right? Things that they're doing that they don't even know that they're doing. And then any sort of unconscious repetition of early relationship patterns. So back to attachment, what was their attachment style like with their primary caregiver, and how might that be playing out in their world now that this acute event has happened to them, either adaptive or maladaptive? So you get to help them figure that out. And then under the social part of the precipitating events, what happened? Was it loss or separation from a close family, partner, friends? Is it interpersonal trauma? Something happening at work? Something happening at school? Did something happen with your financial situation? Did it change? It may have gotten much worse. It may have gotten much better. Both can affect a person, right? Have they had a recent immigration? Have they have to leave their home? Are they in another country? Did they lose some sort of supportive service in their life by having to leave wherever they were? And then is their current experience or symptoms similar to a past situation, right? So are those maladaptive kind of behaviors in there coming up again, or are they using healthy coping strategies? And you can talk about both of those things. And then you move on to perpetuating. So you've got the client that comes in, they come in with all of this stuff already, right? We've all got stuff, we've all got a story. And then this event happens that kind of sends them out of regulation. So it dysregulates them. They come to counseling, which is great. But there's also all of these things in our life that happen all of the time. They're chronic. So taking into consideration the chronic events on top of the acute events that get them there is really, really important. So thinking from a biological standpoint, do they have a chronic illness? Are they in chronic pain, right? Living with chronic pain on top of an acute event that happens is going to be very distressing. Do they have any functional impairments caused by cognitive deficits? Do they have a learning disability? How about a lack of medication optimization? So does that mean That means they don't have access to medication. It also means that they are taking medication, but they're at a suboptimal dose. So they're not getting what they need from the medication. Is there a lack of treatment or follow-up for any sort of mental illness? Are they currently using substances? You always want to, when you're looking at formulating a diagnosis for a client, you always want to think about substance use in there, because that can mimic a lot of other psychological illnesses. It's also can co-occur with a lot of psychological illnesses. So always thinking about substance use. What are their chronic medical problems? Are they hospitalized, right? As a mental health counselor, you can work in a hospital. So is your client that you're speaking with right now, are they hospitalized, and how are they responding to being hospitalized? Or have they been hospitalized in the past, and what was that like for them? And then the degree of their biological symptoms right now. And you can do this on a 1 to 10 scale, right? 1, I'm not having any symptoms, I feel fine. 10, this is the worst day of my life. And you can continue to chart that as you go through sessions with your clients. For the chronic things going on under the psychological realm, so 1 or more perpetuating psychological processes. So again, we're back to those cognitive, dialectical, psychodynamic, interpersonal. So do they have chronic negative thoughts? And are those chronic negative thoughts reinforcing this negative environment for them? So this is where cognitive behavioral therapy will come into play, right? Looking at cognitive distortions and helping to understand the difference between the cognitive distortions and reality, and adjusting your thoughts around there. Is your client help seeking or help rejecting, right? Both come with baggage. That's a good word for that, right? Do they have chronic emotional dysregulation and poor distress tolerance? So is this something that's always been there? They're not able to regulate their emotions for whatever reason. Interpersonally, do they have chronic and unresolved dysfunctional relationships with friends, with families? What's their relationship like with their caregiver? Do they have relationships at work with their significant other? What do those relationships look like? And then, so for psychodynamic, again, this is looking at the themes throughout one's life. So this is your job as the counselor to take all of this information. And if you're coming from a psychodynamic perspective, say, what themes have been present that you've been talking about from the time you were little to the time that you're sitting in my office right now, and how can I help you to understand that what those themes are and how we can work with those themes? And then coping strategies, are they good? Are they poor? Limited or lack of insight? Personality traits, can they maintain interpersonal relationships? And then back again to attachment style. How has their attachment style with their primary caregiver play out in the situations that they're in? That attachment style is always there. It's always going to come up. And then under the social realm, right, perpetuating chronically, are they in, a marriage that's really hard? Do they have discord in their relationships? Do they have even have a support system? If they don't have a support system, that lack of empathy from family and friends can really take a toll. Are the expectations for your client developmentally appropriate? This is really important for kids and adolescents. Are they expected to do things that their brains aren't ready to do yet? Where do they live? Do they live in a chronically dangerous or hostile neighborhood? Are they living in fear all the time? That rises the cortisol in your body and brings you back to the biological realm, but it's caused by the social environment that you're in. Problems of immigration, transgenerational problems, lack of culturally competent services. Again, is racism a factor in their life? Do they have help? Do they have support around what is happening to them culturally? Do they have, a cultural support system to lean on? Ongoing transitions and stressors, poor finances, working long hours, right? I've worked with lots of single moms in my capacity as a school counselor, or single parents, I guess, single caregivers that were working 3 jobs just to make ends meet. That's really, really hard, and it takes a toll on the individual. Are they isolated, right? Are they living in an unsafe environment? And then lastly, you've got your protective factors. And this model does a really good job, again, of looking at what protective factors are. They're really the global factors around the individual that serves to protect them from the risk factors going on in their lives, because we all have risk factors in our lives, right? So what is protecting them and keeping them well? Biologically, are they in good overall health? Do they have an absence of family psychiatric history? So you definitely need to ask them about the psychiatric history in their family. If there isn't one, then that is a protective factor for them. What's their response to medications? Are they on medications? Do they have above average intelligence, easy temperament, resiliency, specific talents or abilities, and not using any substances now or in the past is definitely a protective factor. Not using substances now, but using them in the past is also a protective factor, right? So both can be true. And then under the psychological realm, so do they have the ability to be reflective and modulate their emotions? Right? We talked a lot about dysregulation in the other three predisposing questions, but here a protective factor is the ability to modulate your affect. Do they have the ability to see other people's perspectives? Do they have a positive sense of self? Do they have coping mechanisms that they can adapt and change based on the situation that they are facing? Are they psychologically minded? Are they reflective? Do they have the capacity to change? So this is the opposite of being a rigid thinker, right? Are they open-minded and flexible? Have they previously responded well to therapy? That's great. That's a huge protective factor for them. And do they have good insight? And then lastly, under the social realm, the social protective factors are really, really important. Think about your own well-being as an individual and how important your social systems around you are, how important your environment is. So do you have positive relationships with family and friends? Do you have a supportive community? Do you have religious and spiritual beliefs? That's a huge protective factor. Do you have good interpersonal supports? What about finances, right? Are you just making ends meet, or are you comfortable financially? Being comfortable financially is a really great protective factor. If you have a disability, do you have support around that disability? And then do you have a team around you of healthcare professionals? Do you have a PCP and a pediatrician, a psychiatrist, a social worker, a dentist, an eye doctor? All of those things are protective factors. So this is the biopsychosocial model. Those are the 4 Ps of it. The assignments that you do this week are going to be based on this model. But again, it's something printed out. It's something that I still use with clients. And it really just gives me information as the counselor to really get a holistic perspective of my client and to also reflect that back to them, right? Reflect back the information that they're telling me and the trends that I see from that information. So lastly, this is the last slide in this short little lecture here, are the limitations of the biopsychosocial model. So as clinicians at the level you are at, it is really imperative for you to understand both the advantages and the limitations of the things that you are studying. Everything has both. And when you do research, to be a good researcher, you have to be transparent in both the advantages and the limitations. Everything has limitations, and that's okay. We want you to look through a critical lens at everything that we're teaching you and to form your own opinion about that as well, right? So here's the limitations of the biosocial model. So first of all, it assumes that all mental illnesses are in fact biopsychosocial. So critics feel that assuming every mental disorder to be biopsychosocial actually increases the stigma that is attached to these disorders instead of reducing it. So assuming that a physical injury or effect of society results in every mental illness is not practical, and if assumed thus can also lead to confused treatment, which may have grave consequences. So critics of this model say that some mental disorders can be explained with the biopsychosocial model, but it is wrongly assumed that the model is applicable to every disease. So I'm interested in your thoughts on that. The second one says that some critics feel that incorrect behavior, and they give the example antisocial behavior, cannot be treated as a medical condition, as very rarely do biological factors have a role in inducing it. Critics feel that assuming such behavior to be a disease reduces the credibility of the field of psychiatry, as it seems irrational to classify schizophrenia, which these critics say is a real disease, on the same lines of antisocial behavior. So I think for this one, you need to think very critically, and you can start to think about it now. And as you learn more about the DSM and disorders as we move through problem ID 1 and problem ID 2, do you feel that some diseases are quote unquote real and some are not? And what are your thoughts about that in conjunction with the biopsychosocial model? Again, the next one, there was a lot of research done on teaching the biopsychosocial model to psychiatry students. I personally think that this shortchanges psychiatry students. You have to be really, really smart to be a psychiatry student. And at the top of your field, just like you guys are. And I just feel like, I don't know how I feel about this one, but I'm interested to see how you feel about it. So according to some critics, another disadvantage of this model is that despite intensive efforts, it is very difficult to teach this model to psychiatry students in an academic setting. Not all students are convinced by the threefold approach of the model and are not convinced about its credibility or usefulness. Critics feel that the vagueness of the model and giving equal importance to all three factors in every situation can discourage prospective psychiatry students from the very beginning, thus compromising on the number of students who wish to become psychiatrists. I think the same could be said for counselors as well, but I 100% disagree with this one. It was founded in some very small research studies, but I am interested in what you think about it. This one kind of goes with it as well, that the model can be confusing and misleading for new users to use it correctly and appropriately. So that's why we're going to practice it. The model vaguely tends to suggest that biology and psychology are two separate fields in medicine. This leads to misunderstandings on the part of a new user who may not understand what symptom of a patient is to be categorized in which factor. Again, I think this underestimates the brain power of clinicians and psychiatrists and anybody that's using this model. We've explained it, you've read about it, you're going to practice it. I think that you'll be okay, but I'm interested to see what you think. And then lastly, the biopsychosocial model takes into consideration the effects of society on an individual, including their religious beliefs, primary and secondary relationships, work history, past incidents, etc. However, it can get very impractical to take so many social factors into consideration when trying to analyze a patient's problem. For experts, it can also be difficult to decide which social factors should be considered along with the psychological and biological factors. Hence, critics feel that treatment can get delayed or confused because of the consideration of so many things. I'm very interested in what you think about that one. Like, are we supposed to be considering so many different facets of the human experience in order to treat mental illness, or should we be just looking through one lens? I'm really interested with that. So that concludes this lecture. In this module, your assignments for this week, you have one discussion question and two assignments. For the assignments, you're going to do a self-assessment using the 4Ps template, and then you're going to do a client assessment using the 4Ps template as well. So if you have any questions, please reach out.